Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Alex. How are you doing today?
Oh man, so great to be back with you again. I'm going to have to apologize in advance. I did pick up, I don't know, maybe the plague or something overseas.
Yeah, probably COVID.
Well, yeah, it would be time number 4 or something. So there's going to be some coughing fits. Sorry, there's no cough button on this mic.
That's all right. So today we're going to go through another research paper. Would you mind doing just a quick introduction of the paper?
Yeah, for sure. So let's see if I can figure out how technology works. So this is number 2, I think, maybe in our series.
Yep.
On just article review for the community. And I want to say thanks so much for feedback. I did get a couple of messages over Signal from folks. Unfortunately, because I'm not good at technology, I just recently killed my phone and didn't have a Signal backup. So anybody who sent me messages, I really appreciate your feedback, and unfortunately it is gone in the ether. So please feel free to send me a message again, because some folks actually had some great recommendations for future articles. And also note to self, backup Signal offline, because that is a pretty great data set to have out there. So this article came across my feed recently, and it's a hemodynamic deterioration of trauma patients undergoing inter-hospital transfer, from a pretty reasonable article in terms of standing within the trauma surgery community. So this is the Journal of Surgical Research, and very, very recently published in June of 2024 here, so just a couple of months ago. And then, of course, if you take a look at the authors, which I hate to have some selection bias with authors, but those of you within military medicine may recognize the names Jeremy Cannon and Jay Yellen. They're both quite heavy hitters who were in uniform for an extended period of time and did just a tremendous amount of research, as well as deployed trauma care to our community members. So probably have something interesting to say. Well, let's see what I can do here. All right. Turns out I do have a cough button. All right. And so the question when we first saw this title is, why does this matter to the deployed soft medic? And I think we've all been talking about the tyranny of distance, especially when it comes to Indo-PACOM. But really, if you're in AFRICOM as well, or depending on which part of EUCOM you're in, the tyranny of distance is definitely a buzzword these days. And I used this on a different presentation recently up here in my home state of Montana, because we also, on the civilian side, have the tyranny of distance up here, where my state is larger than the country of Iraq. And some of our EMTs are in the back of an ambulance alone and afraid for hours with critically ill patients. So tyranny of distance, definitely something that we're talking about. And it's not the distance per se, it's the time that it takes to transit that distance where you've got a potentially unstable patient requiring advanced interventions and monitoring. And there's a lot of us who don't necessarily have that in the deployed setting. Fun little background. This came from the Wikipedia page, but the tyranny of distance is actually often incorrectly cited. And there's a great book that goes into the history of Australia and how it being so far from its colonizers shaped it dramatically. But, really getting into breaking down a study from its abstract, this particular study from a PICO approach was the population, and that was a statewide database retrospective analysis from Pennsylvania over the course of 7 years, which is a pretty fantastic and robust data set to aggressively analyze and try and come up with some good analysis of the math. And then next on the PICO, of course, is the intervention. And so what they looked at is of all of those patients in their data set, who was it that deteriorated during transport from a lower level trauma center to a higher level trauma center? And then, of course, their comparator, or who they looked at for their, oh my, it is snowing. Sorry, I got distracted. Their baseline was those patients who were transferred from a lower level trauma center to a higher level trauma center who stayed stable hemodynamically on some very arbitrary metrics there. And then their outcomes, which is one of the things that we like to look at in a PICO breakdown. And their outcomes for the study were many, I think. How would you describe them, Dennis?
The outcomes?
Yeah, because usually there's a primary outcome and then secondary outcomes.
I think so. Their primary outcome, who deteriorated, okay, and it seemed like to me the majority of the people that did deteriorate were head injuries, chest injuries, extremity injuries. Just number wise, it seemed like those were the people that were more likely to deteriorate. As far as, I guess what really threw me is like their criteria for saying somebody actually deteriorated. Mm-hmm. And they picked the classics, right? Their heart rate went up. Their blood pressure went down, systolic blood pressure. To me, those aren't particularly great values unless you're talking about large number swings, which when you actually went into the actual study, I didn't really see giant swings in these numbers.
Yeah.
So it's kind of like, meh.
That's fair. And I think we're going to get into that here in just a second when we really dive down into it. But, fair warning for folks out there. Again, Dennis and I are trying to figure out what is a good way to do this format. And so give us some feedback, please, because this is a new thing and hopefully it's a value add to the community. But we figured we'd kind of do a surface level here, which is what I usually do thumbing through a journal, is I just read the abstract and then flip to the next one. But I think we're going to go full deep dive on this one. And so again, thinking surface level, this is kind of the elevator pitch equivalent that you're seeing at a lot of physician level conferences. It's a 3-box single slide way of breaking down a study. And we're trying to use as few words as possible because I'm a pictures kind of guy. And so, again, if you were to try and analyze this article, what you would say is the background was 50,000 patients that were in the Pennsylvania Trauma Database from 2011 to 2018 that were transferred from a lower level of care to a higher level of care. And there you go, transferred to a higher level of care. And then the methods is who had deterioration based on the arbitrary metric of diagnostic monitoring. And as Dennis mentioned, it was about 10% of patients that had a hemodynamic deterioration. We're going to get into what that means. And then the results. Well, the most important primary outcome that a lot of studies look at is mortality. And usually that's your primary outcome. Now, whether mortality is at 24 hours, 28 days, 30 days, 90 days, 6 months, is all subjective and is very much a point of discussion in the community right now. I'll tell you what's fascinating for those of you who dialed into the JTS phone call this week, and we're recording this on what day? Saturday, November 23rd. Yeah. Hopefully you guys all listened to the JTS phone call this week, in which Dr. Holcomb, one of my all-time military medicine heroes, showed is that all of the TXA studies for head injury showed that at 30 days, there was absolutely no difference in mortality. There certainly is a difference in 24 hours, so maybe you keep people alive longer, but at 30 days, all your head injured patients who get TXA or don't have no difference in outcome. So again, mortality is an odd thing to slice up. This study looked at mortality, in which there was a difference that unstable patient during transport had over 100% increase in mortality. And then all of these other outcomes, and none of them were really the primary versus secondary. They were all either co-primary or just secondary outcomes, which is kind of a messy way to divide up data. And I think we're going to talk about that in a few minutes here. But you can see they looked at a lot of different variables in this particular study. And again, if you want to steal this slide, just hit me up. Happy to give it to you, or anything else. Because as one of the really great French surgeons I was talking with said years ago, if you can't explain something in 5 minutes, then you probably just don't know it well enough, which I thought was a really great way to think about things. And so here's kind of our big picture takeaway on this. In summary, I thought this is definitely a retrospective multi-center study, but Dennis, you and I were chatting about this before we started recording, and I actually think level 3 evidence might be a little generous, although that is technically what the rubric says. What do you think in terms of level evidence? It's definitely not 1A.
I mean, I understand they picked it because it fell into the rubric, so of course, why would you sabotage yourself by putting it any lower? I don't see it being that reliable, and definitely not that reliable for the austere community or pre-hospital.
Mm-hmm. So this is a great time to break it out. I would say in terms of the historic hospital-based, physician-centric level of evidence, this is definitely level 3 evidence, but have you got our Etsy scale for PFC level of evidence? Yes. Ooh. All right. So what would you put this at on the patented Dennis Jarima level of evidence?
So what are we going? 1 through 5, 1 being green, 5 being red. I picked completely randomly. Actually, the same number that you did is probably a 4.
All right.
And I was being generous.
Yeah, that's fair in terms of does this apply to the PFC environment. So that's fun, and we gotta write down what that means for the PFC level of evidence. I know we talked about it once, but pros for this article, again, from a physician-centric, hospital-based approach. It's got a large data set. It applies to the PFC environment in terms of transport times. But if you were to ask some physician scientists about what the cons are, remember, this is not prospective, so there's no randomization to the allocations for the different intervention arms. It's just retrospective, and they really didn't do a great job defining what they were looking for as a primary outcome. And also, because this is retrospective, this was just a description of what did happen, and there's absolutely nothing that they looked at for how to prevent deterioration from happening in the future, which is what I care about. So, and of course, this is one of my favorite stickers from Refractor Tactical, because you just want to get it and go, especially if you've got a critically ill patient. And this is all fun and games, but just at the mortality review yesterday at my hospital, we reviewed a critically ill child that the hospital ground crew messed around for hours at their remote home site prior to bringing this child to our hospital, and there was a really bad outcome, and it was catastrophic to our community. And so this pre-hospital management of critically ill patients is real. It's serious. It has dramatic impacts on pick a community, whether it's the civilian or the hospital-based, and it's really challenging. And the more we can do to optimize this care and give people good outcomes, it's really important.
Yeah.
So I think that's about it. If you were just to look at the abstract of this article, and now maybe we could get in to the weeds a bit. So after you read the abstract, and then started going through the article itself, what did you think?
So when I first started reading the abstract, I was like, oh, like this is looking at something I'm absolutely interested in. And, they kind of picked, I guess, what you would think from the outset. Unstable patients, will deteriorate in transport. If you're having a hard time in the hospital, it's not going to get easier during transport. So, I was like, oh yes, I agree. This is perfect. Then I was like, just for grins, let me actually read the article, and not just, feel better about myself. So I read it and I was like, holy crap, this is a bunch of stuff and it's actually full of holes. And, I don't know if it's actually telling me much that I didn't know already.
Yeah. And so from a structured breakdown review, I think the introduction is pretty easy to figure out. We definitely know who did this, where, when, and what they were looking at. But as far as the methods, I think you had some really good inputs as far as what they chose to monitor the patient. So what did you pick up on that?
So, they picked the main ones that I saw them picking was the heart rate, which everybody knows is incredibly variable for a bunch of reasons. And some of those reasons have nothing to do with the patient's physiology. It has everything to do with the patient's mindset going into a transfer. And the other one is systolic blood pressure. And so, just kind of looking at the numbers, the averages that they picked, the heart rate wasn't super variable. Like it didn't jump from, 50 to 130. It jumped from, high 80s, 90s to, 110s. Okay. So you can be upset and still have a change in your heart rate that way. The systolic blood pressure, though, which surprised me the most, it only changed, the average change was like 2 millimeters of mercury, which isn't even outside the range of, just variance of a non-invasive cuff. So to me, it's like that essentially threw that out of the window, or they should have been more stringent about who they were picking to say that they actually deteriorated.
Mm-hmm.
I didn't see if they were using invasive monitoring or non-invasive, as far as getting the numbers themselves.
Ooh, wow. What a good point I didn't even pick up on that. I'm glad you said that. So yeah, in their methods section for this paper, they did not define how they obtained these different variables. That's a really significant problem. And to be fair, probably their data set from the state level trauma database didn't have that level of information, but that is absolutely a limitation of this article. You're absolutely right. And then the other one that I really liked you brought up earlier is this was looking at those patients who were transferred from a lower level trauma center to a higher level trauma center. And it sounds like for those of you who have only been in the military healthcare system, that may be a little bit of a foreign language to you. So I apologize. That's a blind spot since I've got a foot both in civilian and military medicine. So what was your method for trying to get a better understanding about what those looked like?
So at first the primary method was Google. So I just Googled what does each of the tiers, like what does that mean? What's available, etc. So, level 3, I want to say they have a 24-hour ER, but they don't necessarily have a general surgeon available at all times. They're available, but in my mind, like we got to call him out and he comes in. Whereas level 2, level 1 trauma centers, they have those general surgeons are available, and the other subspecialties are available, on a call at least. So, I mean, that's kind of one of the things I took about as far as, why was this transfer even necessary? My guess, my gut feeling says, a trauma patient comes in, it's faster to transfer them to another center than it would be to call their in-house surgeon in, and potentially that in-house surgeon wouldn't be able to handle it for a variety of reasons. And so they chose to transfer.
Yeah. And so this is a really important point that you brought up, and I'm so excited that you did, is that we all need to speak each other's language. And for those of you, of course, in the military medical community, it's always just so incredibly frustrating when we go speak to another community, whether it's the trigger pullers or engineers, aviation folks. We've all got our own unique language, and really understanding the civilian medicine language is equally important. And these level of trauma centers is something that just gets thrown around in civilian medicine. And if you don't have exposure to it, it's really hard to understand what they're saying. This is especially frustrating because there is the one national definition from the American College of Surgeons about what a level 1, 2, 3, and I think 4 trauma centers are. But if folks don't want to spend the money and be as arduously reviewed by the American College of Surgeons, there are a number of states that also have their own definitions, which are similar but not the same. And so really generally what you see is your point was well taken. A level 3 trauma center often, but not necessarily always, has a general surgeon immediately available. And by immediately, I mean within 30 minutes. Whereas a level 2 trauma center, usually your general surgeon with trauma experience is available within 15 minutes. But really the rate limiting factor there is actually getting up to the operating room for a unstable patient, because you've got to call in your team that's at home, and that can be an hour or more. Theoretically, in terms of delivery of capability, there isn't supposed to be much of a difference between a level 2 and a level 1, except a level 1 is a teaching institution that provides research. But really what we do end up seeing in the civilian practice is your level 2 trauma centers usually have neurosurgery capability, much more so than a level 3, but sometimes not the advanced neurosurgery that a level 1 has got. And then the big one that we end up seeing almost always is shattered pelvises. Those need to go to a level 1 trauma center often, because that's where you end up seeing your fellowship trained orthopedic trauma surgeons. According to the American College of Surgeons, a level 2 trauma center only has to have 1 orthopedic traumatologist, and they're usually kind of the program director. So important distinctions. And then it's really frustrating because that is the exact opposite of what we're used to in the military, which is your role 1 is your battalion aid station. Your role 2 is actually not what we often think of. A role 2 is not the first role of surgery. I would encourage you, depending on your service, to see what they define a role 2 as, but it's often got physical therapy, dental, x-ray, labs, physical therapy, bunch of other stuff. And then, we're seeing the role 3 as the theater hospital. It's got more stuff. There is actually no doctrinal requirement for a neurosurgeon at role 3, but the Joint Trauma System just did come out with a white paper saying how incredibly important a neurosurgeon is if we want our guys to have good neurologic outcomes. And then the role 4, of course, is our CONUS full service centers, which is like theoretically a level 1 trauma center on the civilian side, but in the military, our role 4s, such as Walter Reed, Tripler, are actually not American College of Surgeons verified level 1 trauma centers. So when you start getting in the weeds, it's way more complicated than it should be.
Yeah. Yep.
Yeah. And so then going down from a nuanced perspective and looking at this paper, the methods, and then the results. Did you end up spending any time looking at table 1? Because it's my favorite place to go.
Yes. Yes, I absolutely did.
And foot stomp table 1's important.
Yeah, this is where I started realizing, like, hey, wait a minute, this is not as this is a little kind of a house of cards there a little bit, I think. Especially when you're looking at referring hospital or like point of origin, going towards the next echelon of care, like there wasn't a giant difference in heart rates, blood pressures, which was their primary, seemed like it was their primary determination if they decompensated or not. And those were not particularly impressive. So I'm just a nug. Why do they always pick heart rate and systolic blood pressure as like the determiner of like deterioration?
Well, so Mama always said it's rude to answer a question with a question, but I'm going to do that anyway. So this is just my ignorance because I haven't had the opportunity to come audit your guys' excellent course, which I'm looking forward to. But do you guys cover the shock index at all?
It's kind of hit and miss. Depends on what small groups you're going through. As far as what extra you get out of the group.
Yeah, that's fair.
In my group, I don't particularly go over a shock index.
Okay.
What I do beat to death is what is their pulse pressure and what is the variance between them, because I often find that a student will give a narcotic of some kind. Mm-hmm. The blood pressure will react and obviously go down. And if their blood pressure goes down, that obviously means that they need blood. And so we'll start sending supply that we don't have without actually determining what is actually going on. So just showing them, hey, look at the pulse pressure. How did this react overall? Mm-hmm. Can give you a great big clue on, does he need volume, or does he need some vasoconstriction, or does he need you to chill the frick out about your narcotics and stop dosing him?
That's fair. So to answer your question about why we, in all these studies, look at blood pressure and heart rate, I think it's probably two-factor. One is the shock index, and then two is that's just the easy button, because that's what we always end up seeing on either the patient care reports from the EMTs or in the nursing documentation. That is very easy to find and makes it therefore easy to calculate. Mm-hmm. So I'll tell you, the shock index is incredibly important if you're looking at a trauma patient, which, again, let's remember Rick Caldwell is so great about saying even in Ukraine is only a third of the patients, 2/3 are DNBI. And historically, if you look at GWAT, only about 10% are trauma and 90% are DNBI. But the shock index is heart rate divided by systolic blood pressure, and you get a ratio. If it is approaching 1, then this patient has a very, very high chance of having physiologic derangement and needs fluid resuscitation. Technically, it's supposed to be 0.9. So if heart rate divided by blood pressure is greater than 0.9, that guy meets shock index. But when I'm sitting in the resuscitation bay at the hospital and the EMTs call ahead with a radio report, kind of in my mind, if the systolic blood pressure number is anywhere near the heart rate, I'm already calling ahead for a massive transfusion protocol. And that has, again, been a very well-studied, extensively validated rubric or heuristic, as we're going to talk about later, for a patient who's in physiologic derangement and likely hypotensive. So I think that's why.
Okay. So understood, shock index essentially to me is just how how big of a flag are we waving that this is a bad patient? Do you use shock index in the actual treatment of the patient?
Yeah, for me, absolutely, because that's if I'm giving volume and essentially what my therapeutic endpoints are going to be. And of course, foot stomp, as we all know very well in the trauma patient, the volume of choice should be whole blood, barring that a balanced fluid component resuscitation. And if you really want to go deep dive, I think there's been some really great analysis that, depending on which study you look at, a plasma first component resuscitation, if you have to do components, is probably good. And the way I like to explain this is, if you've got to give components, RBCs carry oxygen. We've got plenty of oxygen. Plasma has volume expansion, and it's got clotting factors. And in somebody who's bleeding, I would love for them to stop bleeding, and the way to do that is clotting factors in plasma.
Yep, absolutely. Just speaking of plasma, we had a podcast with Doug Powell who just like deep dived into plasma and FTP.
Love that guy.
It was a pretty good one.
There's also bit of a tangent, but it's exciting because we are trying with this series here on your podcast to get new data out quickly. There's an article that just got published this week in the Journal of Trauma showing that plasma actually improves head injury outcomes, and we could potentially go into that later on, but that was really cool to see, and that is a growing body of literature there.
Nice. So Alex, let's say you're king for the day.
Yeah.
You can go back in time and you can actually affect the parameters that they're looking at for deterioration. Would you stick with what they've gotten, or would you pick something else?
Way to put me on the spot, bro. Thanks, man.
Yep, you're welcome. You're a PA, by the way. So,
somebody made a mistake. So, we talked about this a little bit before the recording, and the challenge of this being a retrospective study at a state level is I think they were limited to what data they had in their existing database. And for us scientific researchers, we really like that. We don't like the term. We often see the term GIGO, garbage in, garbage out. And as a EMT who sat in the back of an ambulance for many years, I can say that some of my colleagues, never me, but some of my colleagues may have just made up blood pressures while they were in or out in a bouncing ambulance for hours with a critically unstable patient. And so, I don't really know that we can trust this data. And you certainly had some great recommendations about other ways to potentially monitor this. But, the other data point that you had brought up earlier, I think, is the ISS and the AISS. And for those folks out there, there may be one or two who haven't heard of that before. You already did the hard work, the heavy lifting, and went down that rabbit hole. Can you explain to folks what the ISS and AISS is? Because if they're doing trauma reading, they're going to see that score again.
Right. And I will try and get it done within 5 minutes. So just keep in mind, for any provider, I'm coming at it at the aspect of I don't care about it at all. So what the ISS injury severity score is incredibly convoluted. So what you do is you get the abbreviated injury score, and that comes down to different sections of the body. So the head, the face, the chest, the abdomen, the extremities to include, the extremities to include the pelvis, and then external, which I don't understand what that is. Maybe external genitalia. That's about it that I can think of. But, and you rate the injuries in each of those areas. And you rate it between 1 to 6, 1 being minor, 6 being catastrophic, unsurvivable type injury. And there are definitions of that. Alex, you mentioned in one of the surgical manuals, but there is an actual definition of each of those things. So in each of those regions, you grade each of those injuries, and you take the top 3 of those injuries, the top numbers in each of those areas, and then you individually, you square each of those, and then you add them together, and that becomes your injury severity score, which goes from 3 is the lowest number up to 75. And if any of those injury areas are a 6, non-survivable, your injury severity score automatically is 75. How'd I do?
Nailed it. Yeah, you're 100% right. And you did a really great point about looking at that as a variable that was compared in this study between those who stayed hemodynamically stable and those who had a deterioration en route. And what did you see with that?
Yeah, so the top abbreviated injury score was between a 2 and a 3. And that would be a moderate to severe injury. So to me, they're not looking at super sick people. Like, you're not looking at catastrophic injury, which I would assume would be the people that are going to decompensate, or the people that are just very, very severely injured and need, I need like the guy in the state in the level 1 trauma center. He's the only dude that can save this patient. I would expect in that story, yes, that patient's going to have some kind of decompensation along the way. Some of these other ones, like a moderate to severe injury, it seems like, again, this is just my imagination running. It was like, oh, this type of injury happened. He needs a vascular surgeon. He needs a neurosurgeon, just kind of protocolized. And so they sent him. Maybe they're watching super closely, maybe they're not. And there was some moderate decompensation, and they picked on it. So I think in their criteria to say they were decompensated, the flaw was in that systolic blood pressure. I think they should have been a lot more stringent when using that to say, okay, this was an actual decompensation. Like their average should be, 10 millimeters of mercury. Like, this is obvious decompensation, not just, it went down a little bit. There's a bunch of reasons that could happen.
Yeah. Well, and this really strikes at the heart of the matter that we were talking about before we recorded, which is this is a relatively well done paper in a civilian trauma center. It's got a really great sample size. It's broad enough and multi-center that you're able to hopefully exclude any selection bias outside of the fact that it's just in one state. But here's the challenge with looking at this civilian data set is, what was the most common injury mechanism that we saw in this database?
And I believe the most common was head injuries.
Yeah, so the most common one, looking at table 1, which is again where people should spend their time, is 50% of the mechanism of injury was a ground level fall. And the most common area injured, if I remember, was the extremities at about 35%. And the second most, which was right up there at 35%, was head injured. So you've got to kind of piece the clues together as you're really trying to figure out how this study applies to your practice pattern. So appreciate that the most common mechanism of injury was a ground level fall. The most common body area injured was essentially divided equally between extremities or heads. And what do you think the average age was for people who required transfer to a higher level of care in this data set?
Old, if I remember right. Old, fragile people.
Well, as some older surgeons like to say, to tell me recently, old is defined as like 5 years plus your age,
Right.
which is totally true. Because when I was in my 20s, old was 30, and now that I'm in my 40s, it's that definition has changed. But you're totally right. So the average age in this study was 64 years old. They were transferred to a higher level of care because of a ground level fall, and let's just call it what it is. The most common area injured was a head injured. So, fun trivia question for you, Dennis. Here in the great state of Montana, in Big Sky Country, what do you think the most lethal injury pattern is that we are seeing at our state level data discussions?
Grizzly bear would be my gut reaction.
Love that.
But probably falls. So head injury, pelvic injury.
Yeah, you're 100% right. So our air ambulance is taken care of, I want to say 37 grizzly attacks, and our medics and nurses are fantastic out there in the pre-hospital environment doing that, because that's a pretty gruesome injury pattern. But yeah, you're right. People would either guess that it's motor vehicle accidents or firearms, which are up there. But no, you nailed it. The most lethal injury pattern that we have here in the state of Montana is a ground level fall in a geriatric patient population with a head injury. And the reason for that, of course, is multifactorial. You've got, of course, the cerebral shrinkage that we all get with age. So the brain rattles around inside a bit more, which means it bleeds. More importantly, these awful anticoagulants that everybody seems to be on, which causes an increase in bleeding. And you can really go down the rabbit hole. I think the take-home message there is that these really well done civilian trauma articles have very little application and translation to the population that you and I care about, which is a young, healthy service member in a deployed setting. Because if we go back and look at Eastridge's fantastic hallmark study, was it Death on the Battlefield, I think in 2011, he did a really, really great job. And if I remember correctly, I think 2/3 of his fatality cases were blast injury, and the other third were gunshot wounds. Those gunshot wounds were overwhelmingly high velocity, not the low velocity rounds that we see in the civilian practice environment. And thanks to protective body armor, which overwhelmingly protected the head and trunk, you see these high velocity rounds in the deployed environment, which are often isolated to the extremity, which is very amenable to those extremity tourniquets. There's a totally different injury pattern than we see in the civilian environment. So that it's really hard in my mind, after doing both of these for a while, to translate one to the other. What else did you pick up in Table 1? Because there's some other good ones in there.
I'm kind of surprised that the abdomen wasn't higher represented in the decompensating, because it's short of a surgeon. There's not a lot you can do. You get a shattered spleen, or damage the kidney or liver or something like that. Like those are pretty devastating injuries can be devastating injuries that aren't super amendable to external forces, right? And need a surgeon. So I'm kind of surprised, especially with car accidents and etc. They didn't decompensate and die as nearly as much as I thought.
Yeah, you're not wrong. That was surprising. Although I was just going through Table 1 there, and it was twice as frequent in the abdomen. So the stable patients were about 5%, and the unstable patients who had an abdominal injury were about 10%. And then where was the disposition chart? Because there was the straight to the OR patients, and it was overwhelmingly, if you were a unstable patient, you were much more likely to go straight to the OR. But still, the absolute change was not that big. Yeah, here we go. So post-ED destination, there we go. If you're a stable patient, 28% of those guys went to the ICU, whereas if you were unstable, it was 35%. So yeah, 7% difference, not that exciting. This is where they really foot stomped it in the article, but again, I don't think it's that significant. For the stable transfer patients, 5.9% of them went straight to the operating room when they got to the next higher level of care. You compare 5.9% in the stable patients to the unstable transfer patients, in which 8.4% of them went straight to the operating room. So that's a round numbers 2.5% difference. So that's what, 1 in 40? Those just aren't very exciting numbers.
Right. And also looking at like the med surge step down, those are some pretty high numbers. And just, it doesn't seem like this was a transfer that needed intervention. This was a transfer that needed a bed.
Oh man, what a good, I didn't pick up on that. You are so right. Wow. Yeah, or maybe not an emergent intervention.
Yeah.
But perhaps that neurosurgeon that the outlying facility didn't have, or an orthopedic traumatologist.
Right. I mean, the ICU makes perfect sense. The OR absolutely makes sense. You know, he goes, they need the ICU. We're going to resuscitate. You know, like we're going to stabilize him again so that he'll survive surgery, or he'll survive interventional radiology, you know, whatever procedure. That makes 100% sense. But like med surge, step down, like those do not, to me, on somebody who's like really sick.
Yeah, absolutely. And then at the bottom of the post-ED destination is, I think, another eye-opening thing. In terms of absolute percentages, it's pretty small, but 13 patients in the stable transport went directly to the morgue when they arrived at the receiving center. And also 13 patients in the unstable went directly to the morgue.
Right.
Given the difference in sample size, you know, it's a very different percentage, but that's impressive. And, you know, I mean, 144. and again, why we get excited about this, you know, again, out here in Montana is, for example, the next level 2 trauma center from where I'm at is 4 hours by car. When the weather is nicer than it is right now. I'm looking at some huge snowflakes coming down. And we often can't go by air depending on weather. There is one level 1 trauma center in the state of Montana. It's 8 hours by ground. And, you know, from a clinician perspective, sometimes the right answer is to send that patient to another facility that's got a specialist. But it's a huge ask to send these people to another center 8 hours away and then have the specialist look at the patient and say, yeah, you're one of the 144 patients in this study that just can go straight home. And then you've got to call family. And how that does apply in our environment, I think, is especially if you're in a UW or semi-permissive environment, boy, if you've ever tried to flex a plan on how to get somebody out, you're potentially blowing your entire team and scuttling whatever mission you're doing on because you're going to be blown.
One quick question.
Yeah.
So just in your experience, like a level 4 or a level 3, how common are like MRIs or CT or any of the other imagery that people depend so much on?
Yeah, that's a really good question. And I think that's going to tie into something that we're going to talk about here in the end. But so I think your question kind of ties into what tools do you have available to help make the decision on if you can care for this patient at your current role of care or if they need to go to St. elsewhere. Is that kind of where you're heading with that?
Yeah. I mean, if I was, let's just pretend that I actually went to school, and I was in level 3 center, I didn't have an MRI and I got a patient that's like on the edge and I don't know why with my other tools, I could easily see they're like, hey, send him off to, the trauma, the level 2 or the level 1, because if I'm wrong, this will become catastrophic and that's going to be my butt at the M&M talk there. Versus, if I'm wrong in that I err on the patient is fine. They just need fluid or they need a whatever. If I'm wrong and the patient decompensates here, everybody's going to look to me like, why didn't you send them to surgery, which we don't have, right?
Yeah.
So just
Absolutely.
in a overabundance of safety, like, hey, let's just send them out. I can't get the imagery to give myself the confidence that they're fine, so I send them off. I just don't know how common like MRIs or CT are. Like, how far down do they go?
Yeah, and so unfortunately, there's not a great rubric on what is required at the different levels of care from a American College of Surgeons perspective on diagnostic imaging. And certainly the CTs are getting farther and farther down the pipeline, but it's not even necessarily whether there's a CT in your level 4 trauma center, if you have that in your state. It's more, do you have a CT tech to run it in the middle of the night, which is often not the case.
Okay.
But if you are lucky enough to go to the Advanced Trauma Life Support course, which I highly encourage you to go with your PA or battalion surgeon when they go, I really like their approach to a thought process, which is once you've got an idea that your patient can't be managed where you are, stop futzing around and just work on sending them somewhere else. And again, we actually had one of those reviewed this week in our morbidity and mortality report at my hospital, where a receiving center had just done a pelvic x-ray, and based only on that, they said, oh man, we got to ship this out to Alex's hospital. But instead, they sent the patient to the CAT scanner, where ultimately their physiologic compensation ran out of steam. And the worst place to code a patient? The CAT scanner. Yeah. Well, maybe wherever you and your colleagues are working in a far forward environment, that would be the worst. But in the hospital, it's usually the CAT scanner, and the second worst is in the elevator while they're going up either to the ICU or to the OR. And so that was just another great lesson.
Yeah.
But so, your question, and we talked about this earlier, harks back to, how do you make the decision to transfer a patient, or the decision that you can successfully manage and sit on a patient with your equipment, your expertise, your resources, and where you are? And that particular question has been pretty well studied in the civilian literature. And this is an article I pulled up, and I think there's a few of them, but this is the Journal of Manual and Manipulative Therapy back from 2009. And the article's titled, Is Clinician Gestalt Good Enough? Gestalt, for those who may not be up on their German, I think is roughly translated to just what's your intuition, or as adult learning educators would say, your heuristics, based on your skills, training, and experience, kind of what is your gut telling you. And there have been a number of other great studies that have said you absolutely need some pathways, some clinical decision tools to help you. But after you do this for a few years, you just kind of have a gut feeling on where a patient's going to go or what they need. That's also that type 1 or type 2 decision making from, God, who's that really great former military? Yes. Yeah. Thinking Fast and Slow. Yeah. And so in answer to your question, what tools would you need in a role 4 to help make the decision on this patient? I would say the tool you need is you. being a really good clinician and having managed a number of critically ill patients in the recent past in various levels of resourcing, whether that's in a high resource, high acuity hospital where you kind of understand, quote unquote, what right looks like based on some smarter people in the room, which is what I like, smarter people in the room. Or after you get good in that kind of a setting, whether you flex yourself a little bit in a lower resourced area where you are the smartest person in the room, which is a terrifying place to be no matter where you are. And then if you do that, and then it becomes a lot easier over time.
Yeah. I think one of the things I found that have helped me, one, understand the limitations of your equipment. So, like ultrasound, that's probably one of the most advanced imagery capabilities that we have. Time, like you can't rule out an injury with an ultrasound. It's either there or it's not there right now. And so if you have an injury and you're kind of surprised that you didn't find the pneumothorax or the blood in the belly, just wait. Like, don't worry, it'll build, and then you'll be able to see it. So I see a lot of guys, especially when they're in my small group, they do ultrasound early, which is great, but they don't do it again and again and again. They're just like, well, I did it. I didn't find anything. And so, Dennis is just a jerk. It makes me do more stuff. And so they're kind of surprised when things start rolling downhill. Understand, hey, your SpO2 doesn't just run all the time. If there's no blood flowing through the hand, it's not going to read anything. End tidal as well, especially when it's not connected to a cuff tube. If it's like on the mask, well, that air leak from this like amazing beards that we grow, that will throw off your numbers. And so if you don't understand kind of the limitations, and this is the limitation of the measurement that I'm doing, same as like auscultating the chest, or taking a pulse or fill in the blank, whatever measurements or assessments we're doing. If you can't be honest at how good is the data that you're gathering, then that's going to throw things for a loop, and your gestalt is going to be tainted.
Yeah, you're absolutely right. And the limitations of diagnostic tools are something that you can only identify with actual practice on actual patients. And the LARPing that we end up doing in our community with all this notional stuff actually is not super helpful, except maybe just for equipment familiarization. And it's a totally different mindset that we need to get into post GWAT. And you're absolutely right. I was just helping some great dudes do some fantastic training. And it's really hard, even intentionally, when people are talking PFC, to actually get into that reoccurring, reassessing mindset, and starting to take nursing care seriously, which is what we all need to do. And, trying to manage drips, mix up medications, work on all the other stuff that's going to be involved with managing critically ill patients for prolonged evacuation horizons. We all know what that looks like, but actually trying to flex it or figure out how to mix up all that stuff, it's really hard. When I work in the ICU, there are specialty trained subject matter experts who've gone to school for years to do all that sort of stuff. And do you know who that isn't? Yeah, I have no idea how to do all that. There are ICU nurses that are much, much better. And so asking all of our guys who are not ICU nurses, who are not trauma surgeons, to basically do that equivalent. One, I wonder how valid it actually is. But two, you can't get good at that by going to a refresher once every 2 years and then just reading a couple articles, especially articles like this that if you have the time to deep dive, don't actually tell you that much.
Yeah. Yep. Absolutely.
And I can't remember the podcast that Minla Kong did. He was a fantastic retrieval doctor out of Australia, and they'd fly their twin engine planes thousands of kilometers. But he really developed a ultrasound assessment for trauma patients over the hours that it took for him to evacuate patients, and I can't remember the acronym. Because everything's got to have a snappy acronym. But instead of the fast, he ended up doing the slow. And it was just going back again and again and again, doing ultrasounds. And over time, you could develop and see differences, to your point. And I thought that was so great. Because, again, when I used to work in the ER, you do a fast, and then there was either disease or you were waiting for disease to present. But then you just call somebody else and move on. Yeah.
Yeah, as far as determining does he need to be transferred out or not? I think that's the chink in the armor that's going to cause people to transfer patients that don't need it, or not transfer patients who actually do.
Right. And again, to foot stomp, you only get good at this by actually doing this. So I'm pretty sure it was Manny Rivers. He's the guy who basically came up with the sepsis bundles about 15 years ago. And he is a really, really good critical care doctor. And it turns out, unfortunately, based on some pretty bad data, that a lot of the stuff that he initially recommended for sepsis bundles was garbage. But the way that they created that study is that you either got standard care when you were identified as a sepsis patient in the ER, which meant no shade, but just an ER doctor was taking care of a critically ill septic patient. Or if you were part of the intervention criteria, the Dr. Manny Rivers and his entire team of fellows and residents would come down and sit next to you at the bedside. And those patients got better outcomes, and it had very, very little to do with what they thought was a sepsis bundle, and it was more just the fact that a world-renowned ICU doctor and his entire team of fellows and residents were sitting next to you at the bedside. And that's how you get better outcomes, is by having, I don't want to say better people, that's a value judgment, but people who are better at their job sitting next to you at the bedside. And, he even, I'm pretty sure it's him, he's got a test where he'll just walk up to you, the patient who's getting resuscitated, and touch their toe. And his point is, if your toe is warm, you're probably pretty well perfused. And it's those kind of tricks that you only get by doing this day in and day out, managing actual patients.
I mean, you're 100% correct. I don't think it's a trick. It's just, this is what the body does, right? Have you mastered your art enough that you can zoom out and look at the whole picture? Or are you busy looking at, one leaf?
Yeah, I can't remember who the ER doctor was. He was one of the guys on MRAP, which is another great paid subscription. Footstomp, they do a 50% discount for military members. I get no reimbursement from them, but certainly your PA or battalion doc should be getting money to subscribe to that, and they may or may not share that with you. I'm not encouraging anything illegal. But one of the really great ER docs there, when he was retiring, had a great speech. And he said, there's 3 ways to practice medicine: fact, fiction, and effing up. And unfortunately, what I end up seeing in the community is there's a lot of fiction when we just end up LARPing this.
Yep, absolutely. Cool. I guess overall, I mean, we kind of, now that we've spent the last hour stomping on this review paper, kind of again, like, what would you have liked to have seen? Like, how would you have built, looking at the same question, how would you have built it to actually get what you want out of it?
Ooh, well, from a strategic perspective, you often approach these in two different ways. So if you want to be very objective as a scientific researcher, you just want to ask a question and then let the answer present itself. Mm-hmm. If you are one of the guys who already has the answer in mind and you want to come up with a test to get you that answer, that's a very different approach. So I guess the question to you is, what are you trying to answer here? What intended end state do you want out of it?
I mean, what I gathered just from reading the initial one, same kind of question that I would have. I have a bunch of patients. Who's going to decompensate? Who do I have to pay attention to harder en route? Who do I have to say, hey, this is a code beige, I don't know, whatever, to the transferring people so that they pay attention more? Because just like you mentioned sepsis a bunch of times, like the biggest takeaway, pay attention early.
Yeah.
And you save more of them. It's incredible concept. Who are the people that, they scored a 12 on the transfer severity score? Oh, like, holy crap, I better pay attention. Yeah. So you have better outcomes. Like, that's what I felt that they wanted. And that's just me imprinting my own thoughts on them. But essentially after that, they just lost me on, like, oh, I guess you didn't really care that hard. That's what I would want. And I would look to, I mean, who's going to decompensate the most likely? And how do you measure decompensation, really? Is it just going down or going up in number? Like, I don't think that should matter as much as the quantity that they actually move, the vital signs move, and in the context of what. So
there's a burgeoning industry to try and answer that question a little bit better, and it's been using AI for a number of years. And so we're actually seeing more studies that are looking at what you'll see as a multivariate analysis. And so you can actually take this huge data set, basically throw it in the hopper, let it digest, and the computer is going to spit out correlation variables that are associated with whatever outcome you're concerned about. And so that may be a better way in the future to try and readdress your question, is just let the HAL 2000 or whatever AI system you've got out there just look at all the different correlating factors and try and come up with an answer on what is associated with a bad outcome. And to answer your question, what would I care about? I think it would be a potentially reversible bad outcome. So who are the patients that we're going to make a meaningful difference in their outcome if we send them to a higher level of care? It gets a bit more nuanced, though, and we've kind of gone through that, which is, what is the higher level of care providing? We often like to say that it's a single resource, i.e. a neurosurgeon or a fellowship-trained orthopedic traumatologist. But in the big picture, what we actually end up seeing is it's not that single point of failure. And the really classic one that comes up not infrequently, again, in the military, as well as our Alone and Afraid Trauma Center up here, is burns. So burns in particular, much like trauma, are a team sport. And just because you've got one surgeon who's either fellowship trained in burn or has burn experience does not mean that you can manage a burn patient. That needs a robust nursing care system and basically chains of care. And I think that's what we're providing with the transfer, more so than a single resource. But then the intended end state is who are we going to be able to reversibly improve what could otherwise be a bad outcome? And in all of these civilian data sets, what we're seeing is essentially, I would say, this is kind of a jerk thing, but too much noise in the data. If 50% of what we're seeing is head injury patterns from overwhelmingly older folks, those are folks that no matter what we do, they're going to have a bad outcome. And that's actually a discussion point out here, which is we're shipping oftentimes demented, confused, agitated patients hours and hours away, and we're not changing their outcome. We're just making it a really terrible dying experience that's also emotionally impactful to the family. But if that's most of your data in your data set, it's really hard to drill down to the actual injury patterns that I care about, which for you and I, when I wear a uniform, and all the other guys, those are going to be the blunt injuries, the blast injuries, which are very, very rare in the civilian data set, or the high velocity penetrating rifle injuries, oftentimes to the extremity if you're wearing your PPE. Those are super rare to find. And so I don't know how to tease that data out.
Yeah, I mean, clearly we're in a different environment when you're looking at civilian, but at least look at I guess what I would want, that entire data set, and just rewrite the criteria that you selected people, and you probably can get a much better idea. Like you exclude, the 55 and over, right? Let's just, you obviously want as many people as you can, but these people are not necessarily in my environment on the military side or government side. Car accidents, burns still happen everywhere. Gunshot wounds happen. They're low velocity. Okay. Is that super important? Low velocity versus high velocity. Does the ballistics matter that much? Or is the outcome like a low velocity shotgun blast to the liver still pretty devastating? Stab wounds, etc. Like, I think it wouldn't be perfect, but I think we could get fairly close to having at the minimum, okay, this is kind of a thing we're pretty sure of. Well, let's compare that to the military data and see, does it shake out similarly?
Yeah, and I would encourage those folks that are interested to go back to, was it 2021? I think it was 2020. Coatwall et al. Published a fantastic data set looking at mortality specifically within SOCOM. And if you really want to do a ground up approach, looking at what the injury patterns are and where there's opportunity for improvement, that was a really great data set. I'll see if I can find a citation. Maybe we could put it in the show notes.
Yeah, that'd be great.
Because if you talk to Coatwall and Mazahowski, maybe it wasn't Coatwall. It was definitely Mazahowski out of the medical examiner office. A lot of those mortalities are unsurvivable. And so we probably ought to not waste a ton of resources looking at those injury patterns, but instead where we can make meaningful improvement. In the trauma intervention group, the way I like to think about things is people basically fit in three buckets. There's the ones that are going to do fine no matter what we do. There's the ones that are going to expire no matter what we do. And then that gooey middle, the filling of your Oreo, as it may be, those are the ones where we have the opportunity to move them from a bad outcome to a meaningful good outcome, being home with their family. And that number is very small, and it takes a lot of sets and reps to identify those people and then understand how to manage those folks. But that's really the target of opportunity for improvement. And until we identify who those folks are, then we can't really meaningfully direct our limited resources to improving outcomes for our colleagues.
Yep, absolutely. We've been hitting almost 2 hours, so we've done our own version of the Rogan podcast there. So this was really awesome talking to you, Alex, but I think we're going to cut her off there. Unless
That's
there was
too many
something
words.
else.
No, fewer words is more better. I'll work on fewer words.
That's okay. That's okay. Well, again, hey, thank you, Alex. I really, really appreciate you jumping on. We got to do this again.
Yeah, and shout out to the audience. Please send us articles that are recent that you want us to review, because this is for you guys out there. So let us know how to make it better besides fewer words. Other recommendations are always taken. Thanks, man.
Cool, man. Have a good one. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.